So we wanted to talk today about the experience that we've got of Lorenzo and what we've done in terms of the trust. I think the first thing to say that from our point of view, it's not an IT system. For us, it was all about change management and about improving the efficiency and patient safety in the trust. So that's the reason we are doing this section on innovation and efficiency rather than doing an IT one, which I think is a couple of doors down the corridor. So we've done the introductions. What we wanted to talk about was, I was just going to give the executive and board perspective on Lorenzo. We're then going to cover health informatics, clinical content, a bit more of the detail of Lorenzo, including some screenshots and other sort of examples of how Lorenzo works. And then at the end, we'll ask people to come forward with any questions, and hopefully we can pick up any issues. If we can't answer any questions or people want more detail, we're more than happy to do that. And also within the trust, we do run periodic events whereby you can come onto our site. We'll give you a more detailed overview of Lorenzo, and also you can go onto the wards and talk to our staff, including doctors, nurses, and whoever you want to, as part of that process. Just to give you a bit of perspective on Morecambe Bay, we are, as it's shown there on the map of England or the UK, and we cover a large area. We've got a population, which is shown on the right-hand side. It comes to about, our catchment population is about 370,000. The main towns are Barrow, out on the peninsula, on the left-hand side, Kendal, which is a small market town, and then down to Lancaster, the city of Lancaster, which is a large student population. So we cover about 1,000 square miles, and it's very picturesque. A lot of sheep, a lot of hills, but also quite a lot of patients. And at the bottom point there is we get about 12 million visitors to the area. So from our point of view, it's it's not just our resident population. There's quite a lot of visitors. In terms of activity, in terms of GPs, we've got 98% of our population registered with the local GP practices. And 95% of our activity that comes into the trust comes from our two main commissioners, who are NHS Cumbria and NHS North Lancs as well. We operate two acute sites and two main hospital sites, one in Barrow, one in Lancaster, and we've also got a cold site at Kendal. We've got 1,000 beds, and we also operate out of two community centres, one in Morecambe and the other in Ulverston. And the final point at the bottom there is that we get more visitors than, twice as many visitors as live in Scotland. I don't know where we got that fact from, but it's added a bit of spice to the things. In terms of where we've come from, we've had a long-standing vision about the patient record, because our view was that the patient record needs to span the whole health economy, and that there needs to be an easy ability for our clinicians to look at the records in primary care, to understand what's happening in mental health and also in community. Now, you don't necessarily need the same system, but you must be able to absorb information from those systems to get a complete record for our clinicians to work on. So, for example, in A&E, our clinicians can look at a summary GP record for each patient that's registered with our resident practices. And that's going to be expanded out so that all the wards will have that facility, and also down to being able to look at referral letters easily that are currently in the GP system, or other results and so on that are in the GP system in the next 8 weeks. So we actually have a link between, which we'll go into in a bit more detail, between primary care and ourselves. In terms of leadership, there were two things really in terms of the leadership. One is I was allocated the Lorenzo project about 4 or 5 years ago. And also, we've had significant clinical leadership from some of Colin's predecessors, but particularly from Colin in terms of pushing this forward. And it's also been highly visible as our board. So it was all done through business cases, detailed market research and so on as to why we chose Lorenzo. And when we came to that debate, there was a big issue about, do we go to develop Lorenzo as one of our options? Do we wait till it's a packaged product, which is our other option, or do we go out to the market? And those were basically the three things that we looked at. And we decided, because of the capability of our informatics department, the close working relationship we had with CSC and Connected for Health at the time, that we wanted to push ahead and be the development site, because we thought that was, from our point of view, the best way of getting the product. The product initially had a number of issues, predominantly, and this is just my perspective, and is that when it was first undertaken by Connected for Health, it was like, let's design a product for outpatients, and we get 100 people from across the country in a committee trying to design the product, which was, from our point of view, a fundamental error, because we've got a camel, or the initial drafts of the specifications were camels, not what fit for purpose and what we needed. And so the fact that we are now linked closer to CSC and do that development work with CSC means that you've got real frontline people, pushing forward that product. And that's made a massive difference. In terms of change, we saw the project as a change project. And I think anyone going into a major EPR change, you've got to look at it as a change project and not as an IT project. We observed other places where it's headed by IT, and that is a fundamental mistake. You've got to have it headed by your clinicians. So you've got to find, when Colin starts speaking, you've got to find another Colin to get that message across. And you've got to really not just have one or two clinical champions, you've got to get that support, I think, on a wider basis in the trust before you actually press the button to go ahead. We see it as a 10-year project, and Steve and Colin will give an update on where we are in terms of our cycle of progression. The strategic relationship with CSC, we work very closely with CSC around not just the development and design, but also around the testing. And we have a very detailed testing regime. So, for example, in terms of the upgrades we've had since October 2010, those have gone incredibly smoothly in terms of how we've done it. And we use frontline users to test the actual upgrades, not just the tests in the lab. So we do a very detailed testing regime, which is signed off by our users, not by IT or CSC or Connected for Health. In terms of benefits, we have our immediate discharge summaries are done in Lorenzo, go through the MIG out into primary care. So that's all done electronically. So our immediate discharge summaries are done electronically and go out into the MIG. Steve will explain this, and then into the GP system within 24 hours. Now that does again highlight that technically relatively straightforward to do, but you've got to get the clinicians on board to support that process. In terms of infection prevention, our infection prevention team are paperless. They do things, for example, in terms of C. diff monitoring. So they actually look at patients as they come into A&E, and they're looking in remotely to see if they think there's a potential risk around C. diff for those patients. And then they will intervene early rather than later down the pathway. That has resulted in us having a very low C. diff rate at the moment. Compared to previous years and also compared to most of the trusts. We're moving forward now with paperless outpatients, and that project's now well advanced, and we're looking to get that rolled out across the trust within the next 12 to 18 months fully. I'd say part of that is our ability to look into the GP record through Lorenzo, and it all appears as a Lorenzo product. It doesn't appear as separate. You haven't got to go out and go elsewhere. It's all within the product. And Steve and Colin will pick up some other areas of benefit. One of the things we're doing at the moment is in terms of informatics. We've got a substantive base of 75 whole-time equivalents. We are currently working to create a bigger informatics function to include information and clinical coding. Because what when we've looked at this moving forward, what we've got is that a lot of the information provision in real time is done through Lorenzo, whereas the information department tends to be historic. And what we're trying to do, we're going to bring those two departments together and make that all in one, because we think a more business-focused information function is essential. And so, for example, on the back of Lorenzo, we have things like dashboards for outpatients, which tell you, looking forward, 6 weeks and so on, what your fill rate is, where it's not filled fully. And our managers use that to drive performance improvement in terms of fill rates in outpatients. We currently provide services to, two PCTs, which will be the clinical commissioning groups going forward. Mental health trust we provide in the south of the county to mental health and also to our own workforce. We've got 6,000 named users, we've got 3,700 whole-time equivalents, 4,000 trained users, and they've all got smart cards, which again is linked to the national system. So you can't access, which is all again set up in terms of security. So it tells you, Patrick McGann can do not very much. Colin Brown can do significantly more. So what that does is that's given us a much improved security regime because each individual has their own profile as to what they can do. In terms of concurrent users, we've got 600 with 1,500 typical unique logins per day. And what this presentation does is it depicts Morecambe Bay's views and experiences. And we are more than happy to talk about, challenges we've faced. And anyone who comes to one of our presentations will get sort of warts and all presentation about where we are, what the next steps are, and so on. So we're very open about how things look in Lorenzo and what we think of it. If I could hand over to Colin, he'll give you the clinical context.
Right, thanks very much, everyone. I come from this from a jobbing doctor perspective. I'm not a techie. I'm a gastroenterologist. I run a bowel cancer screening centre. So that's very much my background in terms of defining the requirements and functionality needed and usability issues. So what's this all about? Well, this is one of our favourite slides, and it kind of depicts the panorama that we're working within these days. Healthcare over the last 10 to 15 years has got so much faster, more furious, more multi-departmental, more hospital care involved. So it's pretty complex. It's all about this guy here in the middle, and there's about 130 odd healthcare workers that are delivering healthcare for this one individual. And when all these healthcare workers are at different work points, it's pretty clear that paper records are pretty much a passé concept now. So what does Lorenzo give to us? It gives us clinical documentation, and we've got letters, we've got clinical notes, and we've got forms to be able to capture clinical data. It gives us the PAS functionality, including admissions, discharges and transfers, which is pretty core to being able to run a live bed state and to run smaller acute hospitals more efficiently. For access planning, read waiting lists. So we have waiting lists for day operations, outpatient appointments, results awaiting. There's also all sorts of access plans that are set up and monitored, and it allows us to run our clinics. Since June 2010, we've been putting an increased portfolio of results into the results viewing section, and we've got a very wide portfolio of results published and available in the individual records. The requesting functionality has been there for a long time. We are currently unwrapping that at the moment, and we've been waiting for the facility to support pass-through numbering so that the number that's applied to a blood sample bottle on a ward can go to the lab, pass through our analyzers without us having to take off one label and put on a lab label, so so that we don't fall into the problem with errors of mislabeling. So we're unwrapping the requesting functionality now. Emergency care, we went live with at Furness General Hospital in Barrow in June of last year. And we finished the rollout in Lancaster in November last year, and we learnt some lessons in June, such that in November the final rollout was very quiet indeed, and in fact on day one 80% of patients who attended were clinically coded on day one, which was pretty impressive. We can use Lorenzo as a clinical portal and view x-rays through the PACS system, having gone through Lorenzo in the individual record. We went live with TTO discharge prescribing at the end of October 2011, I think. and we're currently just putting the final polish on inpatient prescribing at the moment, with a view to going live with inpatient prescribing around mid-May this year. And we've also gone live with advanced bed management, which allows us to manage wards at the individual bed level rather than just the whole ward level. The whole project has been a big project for the organisation. It was done professionally, and it was a very well run, very well governance project. We went live when the Trust deemed it safe and appropriate to do so, and we went live in June 2010. And overnight, 3,000 users were exposed to Lorenzo. It worked. It didn't stop the hospital. We had no queues outside of clinics. It worked from day one. So we had quite a big team to support the rollout because it was first of type in the NHS. So from our support staff base of about 75, our team actually built up to about 120 for a couple of weeks before go live. And then 3 to 4 weeks later, the team then dwindled down. And we had Trust staff, we had Connecting for Health staff, we had CSC staff, and you couldn't tell the difference. You know, the three organisations worked together. After the experience was a bit bumpy in the early months, you know, which has been well documented. It was first of type, took several months to settle down, but after several months we then went into an adoption phase rather than early life support, where it was becoming much more comfortable for users, who were then becoming more familiar with the system and also more familiar with standard operating procedures. And we're now, I think, in the early to mid part of what we kind of regard as acceptance phase, whereby the content and the processes that are supported by Lorenzo are becoming irresistible, and we're now having clinicians move over pretty rapidly through all the different departments. So having gone live in June 2010, we kind of felt that the software was stable, with a stable platform by November 2010. And what we mean by that is at that point, we stopped looking retrospectively and fixing problems, and we were then at that point forward planning. So it was signed off as a fit-for-purpose piece of software in January 2011. And in terms of a clinical engagement process, this for me is a fundamentally important component of change management in an organisation. And it takes a bit of planning, and it takes an awful lot of energy, which can't be underestimated. But we went live initially in June 2010, and at this stage it was pretty much an informatics-led process, heavily supported by exec directors and a small, enthusiastic bunch of consultants, but nevertheless pretty much informatics-led. I was appointed as clinical lead in April 2011. In March 2011, we had the facility to provide immediate discharge summary letters, and this was such an unmet need over 12 to 14 years. Even though this wasn't done as a specific project, the functionality was so useful that the uptake of this was exponential, and I'll show you some information on this in a little while. We went live with TTO prescribing late October 2011. We went live in emergency care in June 2012, and we completed the rollout in November 2012. We now have a process and a system where we can now set clinical priorities, and that's been offered to us through a reset of the organisation. We've had a new trust board appointed within the last 12 months. We've had a new group of clinical directors put in place, and to my mind, there's two groups within the organisation that we can use for clinical priority setting of informatics developments, and one is the clinical director group, and the other is the nursing and midwifery strategy group. So I'm kind of looking to those groups to be the engines of decision making for the detail. And I'm currently a clinical lead, but within 6 weeks, within four weeks, I'm hoping to be appointed as a Chief Clinical Information Officer. So that's a small piece of the jigsaw in the whole thing of being clinically led informatics. So our priorities from this point are to go live with inpatient prescribing and to roll out prescribing around the trust. So we start that inpatient prescribing and medicines administration in May. We're currently working on developing a maternity module, and again we've had some problems that are well documented in Morecambe Bay around maternity issues, but we feel well placed therefore to be able to define the requirement which we believe will be generalisable to the NHS. So that maternity module is being refined, and we should be going live with that again early part of the summer. We also believe that there's a big need for a theatres module, which is currently out of scope of the national contract, but certainly our trust needs a theatres module to replace our current system, and we believe it would, there's going to be a widespread appetite through the NHS for this. Our trust board has supported and mandated a major project around turning our outpatients into a paper-like system, so that within 15 months we expect that 80% of outpatient contacts will be honoured through electronic support and off paper. We also appreciate that we need to define a strategy, and I've already started to do so, around medical devices, so that whatever clinical data and information is captured needs to plug in and deliver information on the network, which can then be captured and presented through Lorenzo. And as I mentioned before, we're currently unwrapping the diagnostic requesting component, which hopefully will be going live pretty soon. Other priorities for us are to enhance the clinical nursing content. It's probably fair to say that there are some other trusts that are using clinical nursing content to a bigger degree than we are in Morecambe Bay. Birmingham Women's, for instance, are using care pathways, which we're not currently, but it would be really helpful to develop generalisably useful tool sets such as nursing safety bundles. We've done a significant piece of work on that, but we need to just complete that piece of work. Clinical coding via Lorenzo is key for me, and it's really important that my clinician colleagues record and embed structured clinical terms in the records, such as symptoms, diagnoses, operations, comorbidity. And once someone has taken the trouble to put that term in the record, those terms can be used and reused and reused and reused. And it supports quality of care, it supports better comms with GPs, and it supports meeting contracts as well. So that for me is really important. And where it's helped us is that a couple of years ago we had we attracted attention from Dr. Foster over mortality issues. Within 2 years we're coming up towards the middle now on mortality, and a large part of that is underpinned by more effective clinical coding. We need to continue to improve in the fields of user experience and usability. We've had very helpful, constructive discussions with colleagues from CSE over the last 18 months or so. So that whole agenda is moving on to make it easier for users. We need to improve the depth and content within the system. We need to look for how this system will operate with other systems, both internally in the trust, but also outside to, as Patrick explained, develop that kind of single health record across the health economy, and just, not just limit it to our hospital walls. And we've done some work on mobility issues, so we've done some proof of concept work around iPads and building apps that work on an iPad that look like Lorenzo and link in with our database. So we've done some initial work on that. A key component of the maternity module that we're launching in a few months' time is that our community midwives will be working with digital pens to capture information and load it into Lorenzo. As I mentioned before, clinical engagement for me is a really big component of getting things right. To start with, we had a smaller bunch of key clinicians, which, in fairness, have been there since the late 1990s, when we kind of got our thinking going around single patient records. We've always been fortunate to have key executive colleagues support this whole process, and it's important that you know, the driver for this is the strategy and the business objectives set by the trust, that then allows development of a clinical services strategy. And an informatics strategy is there to serve the clinical services and the business strategy. So we're currently looking at another refresh of our health informatics strategy, which gets refreshed from time to time. In terms of the work I've done as clinical lead, I've used all sorts of mechanisms to get the guys on board, corporate emails, trust electronic weekly times. We've done meetings in different departments, including some of the kind of more difficult departments, orthopedics, gynae, whatever. But we came to a point last February where we kind of thought that there's way sufficient value in this, that we really needed a real push to get some of the more reluctant guys on board and read for that consultants. So what we did was to devise a workshop training program, which we called Advanced, because it's consultants that needed that training. It was the same training that SPRs and SHOs got. But we had this mandated by the Trust Board and the Medical Director, and we put this programme together and delivered it in September and October primarily last year, and we now have all but 3 consultants out of about 230 that have gone through workshop training, which is pretty good. And actually the most important output from that was that a lot of guys who went in with eyes closed all of a sudden could engage with and see the value of what this thing would give to them. So all of a sudden we've kind of enlightened the organisation, which is great. And I've done one-to-ones with some of the more difficult guys. The trust mandated smart card possession, and so that was achieved by March of last year. The medical director required clinicians in outpatients that the minimum that they required to do to engage was to have a smart card, to log into Lorenzo in clinic, to bring up a clinic peg board, which is like the work list for that clinic, and to access a new letter on screen, so that they weren't needing paper letters. And that was again another process of helping to drive my clinical colleagues into this system. So we did the workshops. I mentioned that the 2 clinical groups in the trust, clinical directors and the nursing midwifery strategy group, those are the groups that will rapidly increase to their functionality to be the main clinical priority setting groups in the trust. We have the capability to deliver electronic discharge letters to GPs within 24 hours, and that's been mandated as the only process now in the trust of delivering letters. So no paper, no handwritten letters are to be issued from the trust. And at some point we will shut down our generic results viewing system, which again, when we feel comfortable and able to do that, it will be a further drive for clinicians to go into Lorenzo. So in terms of benefits, we did a process of semi-structured interviews with a whole range of staff across the organisation to look at what it had delivered for us. And you can see on the right-hand side the list of different staff groups. And here is a summary of some of the main benefits that we've derived through using Lorenzo as an electronic patient record. And I won't read through this list, but you can quickly scan through and see all the sorts of things that Lorenzo has done for us. So one of the headline wins for us was around discharge summary letters, and we had historic real problems with illegible, flimsy triplicate letters going out, and then having an authoritative type letter going out, but it might be 3, 6, 9 months later, which is awful for GP colleagues. So now we're able to send these legible, structured letters out in very timely fashion to GPs. And this is a graph that shows the uptake. So the facility was made available around February 2011, and you can see a sharp rise in output of discharge summary letters. And this relates to inpatients and not to day cases. But you can quickly see that we're pushing out about 3,500 letters a month on a regular basis. This graph shows in recent times what our delivery mechanism is, and it really relates to what the capability is in primary care and what their preference is. But we can send these letters out electronically. Historically, we've used our own e-postman service, which was an in-house written piece of software. But the important one is the little purple bar, second column, which shows the output from the medical interoperability gateway, which is a piece of technology that allows us to connect between Lorenzo in the trust, in the hospital, and GP surgeries. And by April, I expect that those bars will have changed over. We've just got another 35 practices. 37 practices have signed the agreements, and we're going to be using this technology to transmit documents. So this is what we had, and this is what we were delivering, which was unintelligible rubbish on the left, and on the right we've got highly structured letters with very legible, lots of information, and the information in the box is structured clinical terms that have either been put in the letter and they backfill the record, or they've been cited into the letter from the EPR. So the way we generate a discharge summary letter is to go into clinical notes, bring up a template, and this brings up a templated letter that drags through all of the demographics with it. And then we can place a cursor at the end of each title, and we can SNOMED a term in, be it a symptom, a diagnosis, comorbidity, whatever. So we've launched an input screen, and this is an input screen for a problem, which would be a diagnosis or a symptom. And that now has allowed us to input the term tonsillitis into that letter. Now, having SNOMEDed that term into the letter, that term will also go into the main EPR and stay there. Here we're launching an operation note, so this is a clinical note to record operative details, and the structured term there is, I can't read it, tonsillectomy, so that will relate to the previous diagnosis of tonsillitis. And the pieces of text here have been formatted to suit the particular surgeon who has predefined a canned statement. So they can go into their small library of canned statements, click, and they can drop in a whole load of text that's been predefined for that particular user. So again, that makes it easier. At this point, I'll just pass over to my colleague Steve.
Thanks, Colin. I'm just going to whiz through a couple of the big benefit areas that you probably expect to get from an electronic patient record. So the first one is pretty obvious. You write something once, you can use it many times, and Colin's already cited a few examples of this sort of capability. So if I just what I'm going to try and show you is how we bring in different sorts of results in this particular example. So on the screen you can see highlighted down the bottom on the yellow bar a gastroscopy, and we've got a HL7 interface directly to the gastroscopy system, the endoscopy system, which brings in the structured information as part of the result process. But interestingly, what we can do with Lorenzo, with it being a fairly open platform, a web-based tool, we've added a Morecambe Bay extra down the bottom here that says click here to view the endoscopy report. And what that actually does for us when we click on that is look at one of our local servers, our local web servers within the organisation, that this is completely outside of Lorenzo, and displays the actual report that's gone to the GP. So that's a fairly structured kind of easy to deliver type interface. Colin and Patrick also identified the work that we're doing on paperless outpatients. We've used exactly the same sorts of capability. We've written a little bit of software in the middle to handle the output from the clinical investigation unit. But you can now see at the bottom of the screen an ECG. So this is a 24-hour ECG study, and we do exactly the same. We take an output from the actual machine that's performed the test as a HL7 message and put it directly into the record. The important bit is, if it's in the record, as Colin said before, we can cite it, we can copy and paste it into different areas of the record and different outputs. So that's in effect structured intelligent text. But what we can also do, you can see at the bottom of the screen, a link that we've added. We can then import the PDF image of the output from the machine. The way we've written this Lorenzo extension, as we call it, is totally generic. So we will be using this method to take any output from any machinery anywhere within the organisation. So that gives you an example as to how we can get that information and then reuse it once we've got it. Another big benefit area that we totally underestimated was this one enabling technology. If your organisation is anything like mine, we expect our users to remember at least half a dozen, if not 10 different passwords. Each one of those passwords get you into a system that has a completely unique and different user interface. Therefore, what we tend to foster is a user base that's average at a collection of different systems and different sets of capabilities. By virtue of focusing in on one particular technology, one user interface, our users remember one password, which they now are tending not to forget, but they quickly become expert in that one system, and they quickly start to explore the detail that you would never tend to expect to get if you're running a stable of 10 or 12 different systems. The same fits for my development team and my support team. My guys have now become expert in getting the maximum from Lorenzo. So rather than doing a little job on an endoscopy system, a little job on an outpatient letters system, a little job on whatever, we tend to do a big job once on Lorenzo, and we hit 4,000 users the day that goes live. So to give you an example of that, I'm just going to jump into our e-learning system now. This is a system we call Guru, and it holds, in effect, a Lorenzo lookalike type capability. So our users use this as part of their e-learning certification, but we also use it for some demonstrations. So I'm going to jump into a test record here for Jack Booth, one of our dummy patients. And in effect, you can see down the bottom here something that says GP summary test button. Now, this is an extra button we've added on, and what this button does, it gives us access to the medical interoperability gateway that Colin was talking about. In essence, the local GP record that's sat within EMIS. So this is not the summary care record, this is the GP's detailed care record sat within their in effect, practice database. If I click on that, we've got some strong authentication. We ask our users to confirm that the patient has indeed given us permission to look at the record. This is fully audited both in EMIS and within our systems local to Morecambe Bay, so virtually at a glance we can find out who's accessing what records. If the patient says no, I don't want you to look at the record, our clinicians simply return back to the screen that we're at. The vast majority, however, are saying yes, and we click yes. We jump out over N3 and we connect to the EMIS database in Leeds, and what we're presented with is a view of the GP record at that moment in time. So this is a view we get. Once we finish with it, we throw it away. There's no data exchange taking place whatsoever. It's just a simple view. But what this gives us, what it gives our clinicians, when sometimes they've got no other information about the patient in the emergency department, is a list of current problems, current medication, repeat medication, any alerts and allergies. It will also list recent results that the patient's had, and if we have other views that will give us access to documentation, it'll give us access to end-of-life information for palliative care type patients. And once I click this button, that information has left the Morecambe Bay area. We're about to launch, so that what I've just showed you is now live in Morecambe Bay across the whole of our 4,000 user base. What will be going live over the next 6 to 8 weeks is a slightly different view. It's a cut down view. So as our patients come into an inpatient ward and go through the admission assessment process, we obviously clerk in their medication, and we currently do that really with looking at a bag of pills and having a dialogue with the patient. What we thought was it would be really useful if we could build into the workflow, if we tick this box here that says we want to look at the GP electronic record, that indeed we can actually look at the GP electronic record, but only just the bit of the medication that our clinicians want to look at. So far we've just gone through a standard Lorenzo process. They would do that for any clerking in of drugs. But what we've now presented to the user when they hit the search button is an extra icon, which in effect says GP. If we hit that button, we're presented with the same strong challenge that we were at the detail record point for the whole of the record. If our user clicks patient consent given, we access the GP record, but all we're accessing is the snippet of information that's pertinent to the workflow at that one point in time. So again, what we've done with our Lorenzo extensions development is allowed the user to select a drug from that list, in essence have the dialogue with the patient to confirm that this is what's being dispensed and this is what you're taking, and if the answer is yes, we click on that drug, it immediately puts it in the SNOMED browser and hits the search button automatically for the patient, and if there's an exact match, it finds it. On this little demonstration, I've got to click on that button before it goes to the next stage. Our users don't have to do that, but in effect, then all I do is click on the drug from the search screen, and you can see it's slid across onto the right-hand side of the screen. So with 2 clicks, once I'm into that search area, with 2 clicks, I've got a faithful representation with dialogue with the patient as to what drugs have been prescribed from primary care into secondary care records. Can I just ask how long we've got? 5 minutes. This is probably a good time just to wrap up on. So I'll use this as a final slide. So some key messages from the Morecambe Bay deployment. There's been a lot of mixed press around the Lorenzo deployment in Morecambe Bay going back to before 2010. But I mean, hopefully the big message from us is that the system works. As Patrick and Colin did say, we've not had queues at the door. We've not had a hospital that's had significant problems on its information basis. It's been a roaring success for us. One of the underpinning principles of that success is that our organisation understands the importance of information and its link to safe healthcare delivery. We've got strong clinical leadership. It's absolutely essential for these sorts of programmes of work that it's led by clinicians, but it also needs absolutely strong executive leadership as well. Patrick identified a long-term investment. We are on the cusp now of delivering and receiving some major benefits as a result of the work that we've done over the last 2 or 3 years. I think everybody says this, it's about people, not technology, but it's absolutely got nothing to do with technology. Once the device is on the desk and works, as far as we're concerned, that's all it needs to do. Everything else is about the process and around the enabling type capability of the system. But a key point in that enablement is what we're trying to do is engineer change through the introduction of an electronic capability, electronic patient record. What we're not trying to do is deliver an expensive typewriter that replaces a piece of paper. So an awful lot of organisations start this journey by looking at the paper and using that as your starting point. In effect, you've got to throw that away and start from scratch. If you end up replacing the paper, you do end up with the most expensive typewriter in the world. Again, goes without saying, strong project management, staged approach. And for us, interoperability is the absolute key now, especially not only with primary care, but also with secondary care organisations across the piece. And we're doing all sorts of work with different organisations. I know there's an organisation called Strata out there in the hallway that we're working closely with in Cumbria, that again, we've got some strong links into the Lorenzo screens. So I think we'll leave it there and take questions. Yep.
My name's David Lang and I'm working with Colby Albans for Foundations just at the moment, and to some extent we're just evaluating the different EPR products, and obviously Lorenzo's one that's quite interesting. But I know from previous visits to Morecambe Bay and from presentations like this that you've done an awful lot of work outside the core product. I guess my question is that available to other organisations that might consider Lorenzo, and if so, Lorenzo more attractive than it is just that the core product was available from Connected Realm?
I think one of the big benefits of Lorenzo itself is that it is a proper structured integrated EPR platform, and that's one of its big strengths. What its second big strength is that it's got this open sort of application programming interface layer, this API layer that we've exploited. So you could exploit that ability the same way as we have, or we could come into some sort of collaboration and in effect work together to publish or to build different aspects of what we call Lorenzo extensions. CSC are in the process of writing a formal API that in effect any organisation coming in the future will just plug into. So that the work we've done will get an awful lot easier once CSC have done that.
I was going to ask a similar question. Are you able to specifically share your records with health and adult services of the local authority? Which brings me to, does this help have a really streamlined multidisciplinary assessment of discharge for all people?
Yes, is the answer. It's not something we've done just yet. This falls into the work. I can see Clint in the audience there from Strata. We're doing a lot of work across Cumbria with especially at that complex discharge end of the patient pathway, whereby we could in effect make an electronic referral at any point of the patient's admission, identifying a minimum data set of information, and then pass that with the referral through to social services, through to a hospice, through to a care home, and then track that referral through the patient's discharge to make sure the patient gets the correct sort of discharge at that interface. But I mean, the answer is yes, but we are at the start of this whole interoperability journey. I think the really important answer to the question is that capability exists within these sorts of products now. Yep.
Yeah, should I pick that one up?
Yeah.
Yeah, I mean, we had a very stringent business case, and we delivered the business case within the budget that was set. We did, I mean, I suppose we could talk offline with people about, you know, how many resources you need to actually get the system running and so on, but we did a lot of detailed planning, including things like floor walkers, what testing regimes we were going to apply, and actually, in terms of we actually delivered the projects basically bang on budget as part of that deployment. I think the other thing, probably separately to say to that, is that because it's part of the national contract, Lorenzo, I mean, people probably want to speak specifically to CSC about what that actually means in terms of, you know, in terms of finance and the product and so on going forward.
Yeah, lady at the front.
Have you systematically evaluated the changes in productivity as a consequence of introducing the system?
We haven't done benefits anywhere near as well as we should have done or could have done, and I think one of the things we have noticed through the structured interviews that we've done after we've gone live, so we didn't baseline everything that we should have done. And our excuse is we actually received a whole heap of benefits in different areas, in areas that we would never have expected. So one of the big benefits from the inpatient discharge summary work that we did was in outpatients, because in effect it freed up a crucial resource in that area, the medical secretary, to actually more proactively be involved in the outpatient process. Therefore, GPs started receiving outpatient letters much quicker. We would have never baselined the outpatient work as a result of doing something in inpatients. So I think I think it's always difficult at the start of these very, very, very complex programs of work to identify where your benefits are going to come from. But
you surely need to record them as part of a systematic evaluation process, which feeds back into cost.
yes, absolutely.
Yeah.
Yeah.
Yeah, I think it's a fair point. I think anyone who's, if we were doing it again, it was his first type, things like, I would particularly focus on things like the fill rate in outpatients, you know, what impact that has in terms of additional waiting list savings and so on. And also as Steve highlighted in terms of medical secretaries, because of course we're doing doing all our inpatient IDSs without touching a medical secretary in a sense. So that is quite, you know, it's a significant number. We're now into the day case suites in terms of IDS as well, so they're quite well advanced as well. So there is.
If you don't have a systematic evaluation, I suggest
Yeah, well, I mean, we think in terms of product, for the sale of the product and so on, that is something that we didn't do particularly well, and we accept that. So we're moving into area by area, basically.
And I think we've learnt from that as well, because you know, we thinking hard about implementing inpatient prescribing. We're very well advanced in terms of just putting the finishing touches to the software. We're going live in May, but I think we've thought much more critically about baselining our current operations, anticipating what benefits we might get, so that then we can measure them. So I think we've gone through some of that learning.
I mean, just to say that we've had the sign that our time is up. We'll be outside on the CSC stand for half an hour, so if anyone wants to ask us any specific questions, or feel free to come and see us at that stand. Thank you.
Thank you.